Thank you, Rajam, and thank you all the participants for joining us. We'll be seeing through around 8 to 9 weeks discussing various interesting topics connecting palliative care and pulmonology in coming days. So, as Rajalakshmi mentioned, we have two faculties for today's session. Dr. Sujeet Rajan, he has more than 25 years of experience as a pulmonologist, and he's very active in palliative care in the last few years. And his main area of interest is interstitial lung disease. And we have Dr. Rajam Iyer. Rajam is a pulmonologist, but a palliative care physician mostly now. I'm taking the privilege to say like that. And both of them work together very closely. And she has done her diploma in palliative medicine from Cardiff University, and she's trained a few years back from Pallium in Rajam. And both of them are actively involved in integrating palliative care in respiratory illnesses. They've done a lot of workshops across the country involving so many people and reaching out to as many pulmonologists as possible. And both of them are not just faculty, but the heart and soul of this whole course since the last year. Thank you so much, Rajam and Sujeet. Another year of our program with around 47 pulmonologists from across the country.
Thanks, Sridevi.
Thank you for the introduction, Sridevi. Should I go ahead and start my presentation, Sridevi?
Yes.
Okay, so I will just share screen. Do you have the slide? Can you see that?
Yes.
Right. Can you see it full screen?
Yes, I yes.
You can see it. Okay. So thank you so much, Rajalakshmi and Sridevi. And it's really terrific to know that there are so many respiratory physicians interested in it. I thought we'd have a much smaller number, but I am amazed to see the number, and I think it portends a very good future for healthcare in general in India, not just respiratory or palliative care. When you see so many people interested in integrating palliative care medicine into their clinical practice. So for many of you chest physicians who have joined today, you may have heard me before on respiratory medicine and palliative care, but I keep emphasizing the point that when you start respiratory medicine, a lot is about building your clinical practice, and your success is defined by numbers and wait lists and bed occupancy. And this is what at least 20 years ago or 25 years ago, when I joined a large hospital, I thought would be probably my measure of success, that I would be seeing a lot of patients. And though I never aimed actually for that, I aimed to just probably be a good respiratory physician. And I thought that would be an objective in life. But once you join a hospital, and especially private medical care, which I'm sure many of you all work in, your success is strangely defined by numbers and wait lists and bed occupancy, something that we were not really fond of probably when we studied medicine in a public healthcare space. In fact, we'd be happy if the numbers were less, the beds were less occupied, and we had breathing space those days. So this is what happens when you move to, excuse me, private care. And when you struggle and build that practice, you have excellent numbers, you have these long wait lists, excellent bed occupancy. And I don't know if you have experienced it, but I'm sure you've had colleagues who've experienced this. And they're suddenly the stars in the hospital, or at least viewed as stars in the hospital in inverted commas by the management. These physicians have increasingly less time for their patients, and the patient satisfaction suddenly starts to drop. And when you end your practice and you're about to retire, if you don't have a fixed time at which you're going to retire, which I've again seen with senior colleagues. They have these huge numbers, long wait lists, excellent bed occupancies, and suddenly they're wondering where's the time for the patient and where's the time for themselves. And I think that's where you really realize, and I hope no one here in this group realizes that too late in life, that you don't want your patients not just not satisfied, but you are also having reducing joy in life. And that's the last thing you want in the closing years of your life. So you wonder why I'm saying all this. I think you need to start and end well. And integration of palliative care means you need to enjoy your practice, and you need to really figure this out on your own. And I'm sure every one of the 47 people registered today have different aims and objectives in their lives. And the one thing I can assure you, none of you all, I'm sure, want to be miserable. None of you all want to suffer your branch of medicine. And all of you all, I'm sure, want to enjoy treating medicine with a certain objective in it. It is your practice, your patient's life, your life, finally. And so I would recommend be reasonable and don't struggle. And very, very importantly, value and respect time. And I'll come to that briefly in the end as well, because I think that's something we often miss in India. And I highly appreciate the time at which this whole session has begun, because obviously the organizers value and respect your time and their time. Let's come to why a patient comes for a second opinion. And as you sort of pass middle age, you suddenly realize you're getting patients for second opinions, and especially from a competent colleague. And I've actually tried to analyze that. Most of the time, the reason is the colleague never had time to answer the patient's questions and concerns. And this is real life. I mean, my last consult today was from a very competent colleague who had done everything right. The arithmetic was all right, the drugs were right, but they came because they didn't understand anything about the disease, and they didn't understand what the patient's disease trajectory was. And they kept hoping for, here's a good respiratory physician sitting at Bombay Hospital, I'm sure he has a solution. And if he doesn't, he can at least transfer the patient to his hospital and do something. And so the expectations of a patient are tremendous. And I think we need to get to that base or ground zero first. What are their concerns and questions? And then only will we understand what we really need to deliver in that consult. The second reason is they've communicated but not effectively enough. So they haven't given time, or they've just not communicated effectively. And effective communication is not just a science, it's an art. And I hope all of you all also engage or register for communication workshops, role play. You will be surprised how it changes your practice overnight. And I'm literally saying, like CPAP treats a sleep apneic patient, overnight the patient feels better. It's like that. If you learn effective communication, the next day your practice changes. The third thing is understanding and treating chronic breathlessness syndrome. And this is something we're just not trained in. Because for all of us, chronic breathlessness is something our patients have to now suffer because they're just destined to get it because they have chronic lung disease or they smoked. Understand this is a problem. I mean, the patient has come to you with this problem and your job is to solve it. And if you can't solve it, get someone else to help you solve it. And finally, of course, probing social and financial issues. And I think that becomes a big issue when it comes to clinical practice, because if you don't probe these things effectively, you have missed a large part of the reason the patient has actually come to you for a second opinion. And sometimes they've just been financially depleted, or they're just social issues which are bothering them. So this is actually why people come. Excuse me for 10 seconds. I'll just close the door because there's noise.
This meeting is being recorded.
Okay, so sorry for that. And so that's why patients come in for a second opinion. Another study from Yale, and Sridevi, can you hear me? Because I just went off for a few seconds.
Yes,
Yes, yeah, okay. So the other thing is, what do patients want from their physician? And this was very interesting from Yale, where patients were interviewed. What do they want from their physician? And patients said they want someone they can trust, who is competent and who puts their priorities before anything else when making a management plan. And interestingly, of course, two of these are often not taught in medical college. I mean, I can admit for a fact that I was never taught how to build patient trust. And I was never taught to put the patient's priorities before anything else when making a management plan. In the last few years, that has thankfully changed. I see in medicine that we do have conversations with patients, and we actually teach our postgraduate students that please check what the patient wants, what the patient knows. And so these things have to be built into clinical practice, and they're sometimes not taught. And therefore, and when a patient meets a palliative care consultant, everything here suddenly becomes so robust and well entrenched in the management. So that's where the palliative care physician really enters. You have a new set of eyes, and for those who don't believe that a palliative care physician is required, and I have colleagues who don't even understand what a palliative care physician is all about, I think we need to be just a little ahead of that game to understand what this is. It's just a new set of eyes, a listening capability which is different from what the regular clinician has, a focus on patients' priorities, a lot of time decentralization, and the trust building in a team. And therefore, getting the team managing the patient together, having everyone on the same page so that the patient isn't confused with one person's advice, and hearing out everybody. And if someone has disease-specific therapies to be explored, looking at that, examining the pros and cons of it, discussing it with the patient all the time. And the team or the joint clinic, which we often do now in clinical practice, it just allows everyone to be on the same page. So this needn't be a real estate dedicated to it. And I think many people think a joint clinic means allocation of real estate to a lot of infrastructure and equipment. There's nothing required. It can be just on an email sometimes, and all you need to do is just loop in everybody and say, look, here's my team member who is going to focus on your quality of life, your symptoms, which I may not be really the best person to deal with. I can focus on what I usually tell patients is, I'm going to focus on your diagnosis. I'm going to focus on your pharmacological treatment for your disease specific. And I will tell you the prognosis in the best way I can. But you have a lot of symptoms that are sometimes unrelated to what I'm going to do. And we need to manage that with someone in palliative or supportive care who will focus on that part. And this whole experience, it takes time, but it's worth it, because if you do it in one sitting, I can tell you your patient will be overwhelmed. So if I meet the patient the first day and Rajam meets that patient the same day, that is close to 1.5 to 2 hours of information the patient has got. Not possible for any chronically ill patient to digest. So we try and do it on separate days. And the second time, what I do is probably walk into the room after Rajam's seen the patient and say, look, did she discuss with you what was to be done? And now do you still have questions on what we need to do? And this way it works better, because the patient gets some time to think about whether they even want to meet such a consultant or such a team member. Sometimes they don't, sometimes and very often they do. And it's interesting, they do it based on what the chest physician, that is all of you, actually how you all pitch it to them. A lot is dependent on that. And you can pitch it to them in a way they would never go to a palliative care consultant. This applies to any branch of medicine. You can say that, okay, here I'm sending you to a spine surgeon, but he's going to probably tell you to do surgery. And if the patient doesn't want surgery, they will never meet the spine surgeon. But if you say that this is a surgeon who's going to talk to you about your spine problem and is going to tell you the pros and cons of surgery and why you need it and what will happen if you don't need it, or if you don't do it, they will go probably. So a little tweak in the communication and you've changed the patient's perception. And it's all about patient perception when they leave the clinic. How satisfied were they? So virtual joint consults are increasingly the order of the day, though I'm finding this a big challenge. I'm working on it, but I think the only way to do it effectively is to actually incorporate it in your clinic practice time, which means you need to run your clinic very well and to time. Why I'm saying this is that you may start doing virtual consults on a weekend, on a Saturday morning, because your week is full, or doing it late in the evening. But you must remember that when you do that, you're stretching yourself, which means you're tiring yourself out. So what I'm trying to now do, and I think I would encourage everyone to do, is to probably, if you have to do a virtual joint consult, slot it in your clinic timing so that your day ends at a particular time. Otherwise, it can get endless. And this is what we are seeing with senior colleagues who don't know anything else except clinical practice, practicing till 10 o'clock in the night, outstanding in their field in terms of competency. And then the juniors get the message that a good, successful chest physician should practice from 7 or 8 in the morning to 10, 11 in the night. And that should not be the case. So the primary objective of integration is improving the quality of life and the quality of death. And to tell you where our quality of death is in India, well, we were 67th in 2015. We've moved up to 59th in 2019, so some improvement. A small country like Costa Rica in the Caribbean is 5th. And if you read about this country and its culture of life and death, I think there's a lot to learn from even small countries with populations of under 3 million. So I think we can do better. The UK is number 1, of course. The United States is not far ahead of India. It's about 45th. So wherever you see tremendous amount of private healthcare, you will notice the quality of death just goes down and down. Because many patients undergo expensive, marginal, non-beneficial treatments which worsen the end-of-life experience. And then you would ask, does wealth matter? Well, high-income countries do score better, Scandinavian countries especially. But the differences between high, middle, and low-income, Costa Rica is not a high-income country, are not statistically significant. And so when you look at quality of death in all these chronically ill lung disease patients who come to you, and you'd be surprised how many chest physicians don't want to see them. I think that's the biggest opportunity you have. Take charge of them and just see how much they love you and come back to you. What matters in their quality of life, and definitely in their quality of death, is uninterrupted access to opioids. And there's a lot of research being done on this. And that is important. You need to have your channel where you get the opioids. Integration. Personalized, patient-centered, and integrated. So integrating your team with palliative care. Mandatory education, of course, public education, and understanding this. Because a small change can make a huge difference. A palliative care consultant at one hospital can just change the dialogues in the ICU between the residents and the nurses. And you'd be surprised what a difference it has made in our own ICU where we have been working. And it's experiential, really. You can't even write about it. You have to just experience it to enjoy it. What negatively correlates is no integration of palliative care in the broader health system, poor communication, and the lack of patient autonomy. When a doctor doesn't give patients enough autonomy, that clearly correlates negatively with quality of death. And as Felicia Marie Noll, who was the editor of the Lancet Commission on Palliative Care 5 years ago, that great paper, I think what she said, one line that resonated in that statement, the only thing worse than chemo is not having the choice to have chemo. That's worse. So I think let's remember that. Changing mindset is very important, seeing the patient with another set of eyes, and changing our goalposts from how many patients we see, how much we earn, what's our bed occupancy. As Charles Goodhart said, when a measure becomes a target, it ceases to be a good measure. And this is important. So if a hospital believes it's a great hospital because its beds are full, come back, just reset that. It is not necessarily the target of good healthcare. Peter Drucker said, if you can't measure it, you can't improve it. So then you need a measure, right? He was the guru of management. But what do you measure? This is what you need to measure. And we never measure this. Prolonged hospital stay. Private hospitals are indifferent very often to it. ICU issues, suffering, costs, drug adverse effects, mental stress of the caregivers and dependency. That's what needs to be measured. And so if we measure this, and I really plan to do this, it's been a while since I've been thinking of it, but actually just give a form. How many patients leave your clinic satisfied? It may give you an ego trip, but it's worth it, because if they leave your clinic satisfied, you've done your job, with them at least. How many patients with chronic lung disease are suffering less after they've met you and over the next few months and years? And how many patients leave an indoor admission satisfied? You'd be surprised how many don't. And I think that's what we need to measure. So to conclude, you can't manage chronic respiratory illness without being trained or associated with a palliative care team. Trust me, you will not do the right job here. Wealth matters, but it is not often correlated with better care or health care. And measuring patient satisfaction and quality of life and death are extremely important endpoints in overall health care. Integrating palliative care is very important. If I have to give you a few tips on my last slide to integrate, invest time. Time is critical, and value your patient's time. If you do these two things, I think invest your time, value your patient's time, you will never be running short of it. And if you can't invest time, decentralize it. And that's what integration is all about. Palliative care physician, ideal. If you don't have one, get your psychologist, rehab physiotherapist, clinical assistant, or nurse assistant trained in it. One of the two things you need to do if you don't have a palliative care physician, and you will see the change happening. You'll see it the next day, the satisfaction. And finally, of course, you can't do anything of all this without effectively communicating. And this can't be learned in a lecture. This needs to be learned experientially. So I hope Rajalakshmi and Sridevi will be organizing workshops on how to communicate better for this group as we move forward. Thank you very much.
Thank you so much, Sujeet. I think we can take questions in the end, Rajam, after your presentation also.
Either way is fine. I mean, whatever. If there's a pressing question,
We can take the questions in the end, probably.
Sure. If there's a pressing question that anybody wants to ask Sujeet, they can go ahead. Otherwise, I'm happy to share my screen.
Yeah, that would be great. We can wait for another 2 minutes. If there are any questions to Dr. Sujeet, we can. You can either unmute yourself or you can type it in the chat.
If someone wants to put a question on the chat box, that's also fine if they feel
There's
able to ask. Yeah.
Compliment to you.
Thanks.
Rajan.
Thanks, Rajan. Please feel free to put the questions on the chat so that you don't have to vocalize it if you want to. And I think we would like to know where one is deficient in the presentation, what one can do better when one does this next time.
I actually have a question. Am I echoing?
No, I think that's from the Sujeet's speakers. So when he's muted, it is not echoing.
Okay.
Am I echoing?
Not you.
Not you.
I feel I am.
Can you try now, Rajam? Now it won't.
Better? Can you hear me?
Yes, yes,
ma'am.
yes.
I just have a comment or a question to the participants. I mean, I have heard Sujeet before talk about how important it is and how it's made a difference to his clinic and the outlook to which he treats patients. But I'm not sure this is what the participants actually thought they would hear. So I just wanted to know how. I know one of you commented on how good it was, but it's something which is not medical, but so medically important and relevant for your own quality of peace of mind and quality of life, and as a pulmonologist. So it'll be nice if you could give us feedback about how different you thought it was from the other medical lectures or seminars and webinars that we have so used to attending. So just for us to get a feedback, because we also want to know, like Sujeet said, where we can change and where we can improve. But keep your comments coming and let it be interactive. I'll get on to my talk, because I know you all had a day and a week long of whatever 8-10 hours work, so I won't take much of your time and we'll proceed. So with your permission, Sridevi, I'll go ahead.
Yes, Rajam. Sure.
Okay.
And if you have any questions in between, please put it in the chat so that so that you don't forget to ask in the end. You can take it up.
Yeah, Sujeet has got another shabashi about quality of death from Suresh Kumar. So that's very interesting to know that one of our participants had heard it for the first time. So I'm glad we are doing this, Sridevi. Thanks to you and Rajalakshmi. So I just wanted to take on from where Sujeet has left. So I'm also a trained pulmonologist, trained 1 year after Sujeet did in Bombay, and we both practice in Bombay together now. And the transition from pulmonology to pulmonary palliative care has been quite interesting, and I think I've managed to do that in the last 5 to 6 years only. So I'm very much junior in the world of palliative care, but it's been a phenomenal 5-6 years of training, learning, meeting new friends, and also making a big difference in patients' lives. So I just wanted to briefly touch upon that. So it'll also probably help you think of what you can also do besides being a pulmonologist. So this is something I grew up listening from my grandfather, which reads Anayasena Maranam Vina Dainyena Jivanam, which is very, very crucial in our house, because my grandfather used to say it and pray it every day, morning and evening, which meant praying to the Lord to give a death without suffering and a life which is disease-free. And this is something which is actually in our scriptures, in all the religions, about how as doctors, we need to focus on the suffering of the patients. And somehow in our learning and somehow in our, over the years and commercialization of medicine, suffering is something nobody budgets at all. So my journey started after reading this article of Dr. Rajagopal in the Times of India as an op-ed in June 2016, exactly 6 to 7 months after I lost my father with a stroke. And following this, I took myself to Trivandrum and trained in Pallium, India. Then these two gentlemen, who also are associated with a big hospice in Bangalore, Dr. Nagesh Simha and Dr. Jeremy Johnson, encouraged me to do the diploma in Cardiff. And of course, Sujeet and a very dear colleague, Dr. Roop, who's a neurologist, are the ones who encouraged me to actually focus on non-cancer palliative. And the real world has really opened up for me, because today my practice largely is chronic advanced lung diseases and neurological conditions like Parkinson's, MND, stroke, Lockton syndrome, PSP, dementia, where really there isn't a cure. So coming back to emphasize to all you young minds as to the need of palliative care in respiratory medicine. Yes, we all realize that historically palliative care began for looking after cancer patients, and a hospice was started in Europe in the late 60s to look after patients who were dying with cancer. So therefore, somewhere in the minds of doctors and healthcare professionals, even today, Palliative care means looking after cancer patients and looking after cancer patients when they are dying. And hopefully by the end of today's talk, both these myths will be busted. And the reason for that is on this graph. Now, this graph needs to be a little bit updated. But if you see today in India, the number of people suffering from non-communicable diseases or non-cancer diseases is a huge population, which includes people with diabetes, blood pressure, cardiac illnesses, chronic respiratory illnesses, unfortunately also infective conditions like tuberculosis. A large amount of our population is affected by these illnesses. And if you will all agree, conditions like COPD, interstitial lung, diabetes, coronary artery disease, hypertension, dyslipidemia can all be controlled to some extent. It cannot be cured. So what does that mean? A large amount of the conditions we see are either cured, which is probably infection diseases, 1/3 of them. 1/3 can be kept under control, and 1/3 is actually incurable. So what are we doing with 2/3 of our patients where we cannot cure their condition and we only manage to control them? We therefore need to handhold them through their journey. And palliative care or supportive care is exactly that. So if you see, all chronic illnesses need the support of a palliative care physician, which might not be, a specialist palliative care. It could also be a general palliative care where a simple MBBS doctor can look after chronic illnesses. But when you have a patient with a complicated advanced chronic lung disease, if the pulmonologist is aware of the integration of palliative care, life becomes win-win and easy for the patient, for the pulmonologist, and for the palliative care physician. So this is a graph. I mean, these are the numbers that all of you will be aware that the rising number of multi-drug resistant, extremely drug resistant, and totally drug resistant tuberculosis, their life is also very, very difficult. We might not really have a cure for them, and they do face a lot of physical, social, emotional, financial distress. And we, along with Sri Devi and a few doctors across the country, are now forming guidelines for palliative care in the treatment of tuberculosis. Along with that, of course, is the airway disease, especially COPD, and interstitial lung disease, which is on the rise. I do not have to tell this team of doctors about the current status. I'm sure we are seeing more and more of these in our OPD. Along with this is the additional problem in India is that we are now in the next 30 years going to be a gray nation. The statistics are staggering. The number of people who are going to be 60 is going to increase by 300%. And people like me will live up to their 80s. And that's going to be a whopping 700% rise in 80-year-olds. How are we going to cope looking after this population? Now itself, I realized that from the time I trained to become an MBBS doctor to now, in the last 30 years, the number of octogenarians and 90-year-olds in every household is already increasing. So we are going to be burdened with elderly population. And as you grow old, the number of chronic illnesses is obviously going to rise. So we need to be prepared for this epidemic of elderly who are also going to be sick. So just coming back to point out to you the manner in which, just to bring back to you the focus on why we need to integrate palliative care in all specialties, the manner in which people die in the world can be largely split into 4 ways. The first, of course, is sudden death, where there's no time for palliative care. The second graph B is where 22% people approximately die that way. And typically it is a trajectory seen in cancer, where patients enjoy a decent quality of life and then a slow progress towards death. And that is where the seek help for palliative care is integrated. And somehow cancer deaths is more predictable because there's enough research done about 5-year survival, about the TNM staging, about the grades, etc. Come to graph C, and this is the problem that we all face, whether it's renal, cardiac, liver, or chest diseases, where the patient is diagnosed probably at the age of 50 or 60, say in a COPD, and he lives up to 80 years of life. Now, in these 15 to 20 years, he has multiple punctuations of hospital admissions. And every time he gets admitted, his quality of life becomes poorer and poorer and poorer. What we do not realize here is what happens to the patient besides the acute admission. You and me as pulmonologists look at the patient only during acute admissions. When he goes home, is the patient self-caring? Is he able to eat? Is he depressed? Is he stuck on his bed? Is he able to do physio? We don't know the dynamics of the family and what is happening in the family financially and socially. Typically, if you see, therefore, our patients with organ failure live a very prolonged period of time with high symptom burden. And the whole journey is not only difficult for the patient, but also for the caregivers. So if you have looked after a grandparent or a parent with any chronic illness who constantly needs monitoring or constantly needs reassurance, help, to take him to the toilet, to make him wash himself, to take a bath, take him to the doctors, the dentist, you realize how much of your life is invested in these people. And it is a burden, not just for the healthcare system, it's also for the caregivers. So these patients are the ideal patients who, if you integrate palliative care with the specialist, what happens is a large burden of the patients and the family is actually helped to take care of by the palliative care team. And the last, of course, is the frailty. Like I said, we have elderly patients who are just getting old. They have no issues, but at 90, 92, they've obviously become frail. You think of the patients with dementia who live for 10 years, and what happens in them? There are people who still bring them at 8 or 10 years to the casualty for aspiration pneumonia. And that's the time that's time which is too late to think of what and how we should treat. And unfortunately, very often in private hospitals, we do see these patients being ventilated, and therefore it is adding to the poor quality of death in India. So just imagine a family wherein everything is fine, and when one member falls ill, the transition comes from wellness to illness. And if that illness is incurable over the next few months or years, when that person dies, that person definitely creates a void, and it is a social phenomenon where a member of the society is lost. Therefore, if we think of what is actually happening is not just the physical suffering. So in palliative care, we talk of total pain, which not only includes physical, but it's a lot to do with emotional, psychological, the sense of loss and grief, logistical problems, caregiver issues, social issues. And you will agree with me, when you think of your patient with COPD or ILD stuck to his bed with his oxygen, he probably dies a social death before a physical one. And all the issues that come because of the breathlessness. So we do not budget suffering, and we do not think of total pain. We stop at cough, breathlessness, hemoptysis, chest pain, etc. We don't know how all this changes the patient's life. So this is what is palliative care, where we think of not just the patient, not just his symptoms, but also other issues that contribute to his worsening. For example, his mental status. For example, his financial status. Does he know how bad his illness is? How much does he want to know? Therefore, what is his choice of what to do in an emergency? So unless we educate the patient and inform them of their disease trajectory, they are not going to be able to decide how to treat them in an emergency. Currently, the communication is so poor that none of the patients are prepared. If there's an acute attack of emergency, they land up in casualty. From casualty, it's a conveyor belt. It's ICU, ICU BiPAP, BiPAP venti, it just keeps going on. So in a condition which is chronic, which is got no cure, we really need to intercept with sensitive conversations, give them the information, let them have the time to think, process, analyze, so that we can give them the best care possible, which is in their best interest. Therefore, our domains of care in palliative care is not just physical, not just the disease management, but involvement of social workers, counselors, physiotherapists, bereavement counselors, and give them practical tips of how to manage their illness and how to cope, because we are not going to be able to change the outcome or the illness or the condition of the lungs. But what we could do is make the journey bearable, be the support, the mentor they need during this difficult journey, which can be for many patients more than a decade. So we therefore would like to integrate palliative care along with curative care. Very often, what happens now is many specialists say, I can't do anything more for your breathlessness or your illness. Now go to this palliative care team. It is almost like abandoning your patient. If you integrate it with the curative care, as the curative care phases out, you can smoothly transition into palliative care. We are introduced as team members, so patient know we are under shared care. So that patient knows that the condition and the underlying illness will be treated by the pulmonologist, the primary consultant, and the palliative care team will look after all the other issues. And believe me, it saves a lot of time, and in some case, even a persistent repeated questioning from your patients, because they have so many questions. You are a busy consultant. You don't have the time or the bandwidth to deal with them. It really helps to answer questions of the patient about simple logistics. How do I get to the hospital? Whom do I call? Where do I go? All these things can be taken care, and we are a team of people. So it's not just one other consultant, but a counselor is on board, the physiotherapist is on board, there's a social worker, and actually volunteers. They make a big difference because they have looked after these patients in the past. Relatives of patients of COPD, stroke, ILD can actually give you hands-on tips to the relatives of other patients currently looking after them. So our dream is to really integrate as early as possible so that the patient and the family and the pulmonologist and the palliative care physicians suffer less. There is a lot of focusing on what we could do to improve their situation. Because, like I said, any chronic illness is, you could actually compare it with like falling off a skyscraper. Today, what happens is the manner in which you land depends on the way you fall. So nowadays, what we see is we wait to talk about how bad the patient is till it's too late. It's almost the patient is on the first floor and says, sorry, we really cannot do anything. But if the fall, which you know as a physician, you have seen many patients of COPD. You have seen many patients of interstitial lung disease. You know the trajectory of the condition. It is therefore your onus to have timely, unhurried, sensitive conversations with the patient and the family so that you can foresee and foretell what's going to happen to the patient. At least it gives them time to prepare, process, and analyze, come back to you with more questions. And that's the stage where you say, look, I really need to involve my palliative care physician. We can sit together and ask and solve all your questions. And they might ask many questions because you have the children who are spread over across the world. We do Zoom meetings across so that everybody's on the same page. We answer their question, explain to them the futility of aggressive, invasive medical treatment in the ICU for certain patients of interstitial lung disease, for advanced COPDs, and therefore we see to it that they are prepared for an emergency. Like Dr. Sujeet has also shared previously a beautiful slide that you and me will really like to learn to swim, not in a storm, but when the sea is calm. And when your patient is outside the ICU, ready to get in, that's probably the worst time to discuss about what to do next. Should he be intubated? Because nobody has the mind space, and the amount of emotional distress at that time is so high that nobody wants to sit and listen to you or talk to a new face. Therefore, we really need to acknowledge what are the issues that our patients with breathlessness have. Typically, when a patient of COPD or interstitial lung comes to the OPD, we ask, are you feeling less breathless? Is the cough better? Are you sleeping? Are you eating? But we do not go beyond this difficult questions of, are you coping with your breathlessness? Are you, because the issues are frustration, irritability, anger. This was a person who first was the one who was actually the person who was running the house. He was the role model of the house, and suddenly he's become completely dependent. He can't even wash himself. He can't even pick up the phone on his own. He's stuck to his bed, stuck to his room. And there's a constant anxiety and fear, which leads to frustration and depression. This is something we find it very difficult to ask, and we find it extremely difficult to cope with when the patient opens his Pandora's box. So the one way to change this way of asking is, what have you stopped doing because of your symptoms? How has life changed because of your breathlessness? What is it that you love to do and you can't do anymore? You might not be able to make him do those things, but the fact that you asked and the fact that you acknowledged his distress is a huge relief for the patient, that you really care how his life has changed. So very often we ask, is your breathlessness better? Are you breathless or are you better? Change that, saying, what have you given up to avoid breathlessness? And typically you'll realize how simple things, playing with grandchild, gardening, going for a walk, like to go to the supermarket, this, or even, for example, go down and meet friends for a chat. These things change a lot because social fabric is so important for all of us, that we realized during the pandemic when we were forced to be with ourselves. So imagine the patient who is not able to do it because of his physical restraints. And this is typically the model explained beautifully about how our patients are caught in this vicious cycle of the breathing, thinking, functioning model, where a breathless patient is constantly anxious. His mind is the only thing that is overactive. And because he is breathless and because he is anxious, he refuses to budge from the chair. He says, if I walk 2 steps, I'm going to get breathless. Let me not walk at all, and continues to get deconditioned and stuck in this vicious cycle. This is where beautifully palliative care team works, where the pulmonologist looks after the breathing, the psychologist looks after the thinking, the functioning is looked after by the physiotherapist, and therefore we try to break this cycle in order to improve the quality of life of patients. So these patients might not be able to go run a marathon, of course, but for them, eating a meal with the family, going to the toilet on his own is his marathon. And it really improves his quality of life, his dignity, the respect that he doesn't have to depend on another person to take him to the toilet. So we really don't think of how our patients are leading lives. I realized these things when I became the caregiver at home for my 80-year-old dad, and now that my mom is also 80. We realize this only when things are hit home, but our patients are suffering this life for a very long period of time, and you and me can make that difference. Sujeet also mentioned about chronic breathlessness syndrome. This was coined in 2017, where it describes the situation in which most of our patients with advanced lung and cardiac and some amount of neuromuscular diseases are. So this is a situation when a patient continues to be breathless despite optimum medical treatment for his underlying condition, and when his breathlessness affects physical limitation and adversely affects his psychosocial, financial, spiritual problem. This patient, when he's continuingly breathless, despite all your medications, therefore you need to scratch under the surface and ask him, hello, what is bothering you? And that's when the Pandora's box opens. We need to recognize chronic breathlessness syndrome in patients with advanced lung diseases. And there is a lot of things that we can do non-pharmacologically before we start dishing out prescriptions. And simple thing like a battery operated fan. More details will come to you during the lecture in breathlessness, but simple tips of battery operated fan blown to the patient's face reduces the sensation of breathlessness without any oxygen, without any nebulizer. Then breathing techniques, positioning the patients, as well as the distractive therapies like pet therapy, music therapy. So there's a lot of things that we can train our caregivers to do when a patient gets when a patient of chronic lung disease gets acutely breathless. So there is a lot of non-pharmacological, which can be done by physiotherapists, counselors, social workers, volunteers, the caregivers, before we get to the pharmacology. And amongst the important thing in pharmacology, that all of that listed on this slide, you already know. Morphine is something we are not trained to use in our medical, both undergraduate and postgraduate training. This results in an opioid phobia for prescribing doctors, for the patients, for the caregivers. There will be a session on morphine, low dose, effectively used to treat breathlessness. And I have patients who now walk to the clinic with advanced COPD and interstitial lung disease, are able to enjoy small pleasures of life with low dose effective morphine. And what I could what I can vouch and say that at least 80% of patients benefit enormously with low dose opioids reviewed closely and the side effect of constipation treated sensibly. Besides breathlessness, you and me need to learn about palliating distressing cough in interstitial lung disease, pleural effusions in malignancy, which is recurrently filling, hemoptysis, when you know this patient is going to have hemoptysis, how to manage, as well as other symptoms, which often Sujeet says it's really difficult when patient says, I cannot sleep, I cannot eat, I have fatigue, or I'm anxious. So these are the other things we need to at least address and acknowledge and refer them to counselors, to psychologists, and to the palliative care team. So these are distressing symptoms that all our patients face with advanced lung disease. And all of us have gone through this hell of the pandemic. And I think we would have handled the pandemic better if most of us were trained in palliative care, because medical ethics, whom to admit to ICU, whom to put on the ventilator, what are the conversations we need to do with a 90-year-old COVID lung, not putting on the ventilator. So these are the challenges we have faced, and there is lots to learn about ICU and palliative care. Withdrawal of care, withholding of care, both of which allowed by the Supreme Court, and it's medico-legally, ethically right if it is not in the best interest of the patients. Difficult dialogues when you're sending a patient advanced COPD home. We need to have a clear-cut goals of care. Is he coming back next? Does he want to come back to the ICU? Should he be intubated? Is it in his best interest? It is our duty to explain this so that the patient makes an informed choice. Very, very important. Therefore, what can we do together? Communication is one. Think and plan ahead. And also discuss living will and advanced medical directives, which is, of course, now in a much more logistically better in the Jan 2023 judgment of the Supreme Court, where they made it much easier for patients to write their living will. And we try and do medical care with ethics. Very, very important. And the first pillar being autonomy. We must ask and give our patients choices, because tomorrow we will be patients and we will hate it if somebody dictates to us what should be done. We need to have the right to choose how we should go ahead. So this is another very interesting person from which I have learned, when we all plan our holidays, we always think of where to go, how to go, who will pick up, book the seat, book the cab, book the tickets. And when it comes to the last journey of our life, it is the ICU doctor or the casualty doctor whom we've never met. Who should be planning the last journey of your life? It has to be you. It is your life. It is your decision and your body. So patient needs to be given that respect and the dignity to choose how he wants to exit this world. And it's extremely important. This is a slide which is busy, but I just want to put it to trigger conversation. And this is often what we do when a patient is in advanced lung disease at end of life, is when we use palliative sedation, which is a combination of morphine and midazolam, which is given subcutaneously at a very low dose and low rate, just 24 to 48 hours approximately before death, never goes more than 3 days, when we are sure the patient does not want to be in the ICU, does not want to be ventilated, is at the end of life. And this is after a series of communication and documentation with the patient and the relatives, because the patient will be unresponsive after the drip is initiated. And this is so that the patient transitions in peace. The intent is comfort at the end of life. The intent is to maintain what the patient wants and how the patient wants to be treated at the end of life, and to decrease suffering, and so that he and the relatives do not have this emotional turmoil to see the patient suffer just before death. And death is something which none of us talk about. Doctors are also not trained to talk about death and dying. We treat death as a failure. Despite seeing it all the time, it becomes very, very difficult to accept death, and that needs to change. We need to get more comfortable to talk of death and dying with our patients also. Unfortunately, a lot of barriers to palliative care. It starts from physicians, the doctors, the patients, the family, the community, because nobody wants to think of death. it is important to plan death. It is better to have those conversations than not at all. Because the suffering for patients who've not had this discussion is way higher than that. And it's important for us to remember that we live every day, we die once, and we need to get that right. And it is important, therefore, to add quality of life to our patients' years, not years to their life, because prolonging a poor quality life is also torture. So there's always an end to cure, but there's never an end to care. And you and me are actually healthcare professionals. So we cannot afford to forget that even if we are not able to cure our patient, you and me must continue to care for our patients. So it's extremely important for you to timely integrate palliative care in your disease trajectory of your patients. And the future sessions will actually tell you in different conditions, symptoms, as well as the indicators that we have to when to integrate palliative care. Because very often pulmonologists come with this question of talking about palliative care too soon actually removes hope from the patients. So the timing of the referral also is extremely important. And there are typical indicators, and there are couple of very good papers which Pallium can share with you about when to integrate in COPD, in Parkinson's, in MND, in chronic liver disease, in chronic cardiac disease. And therefore you get, tuned to the fact that, it's time probably to integrate, because even the patient needs time to think about it. It's easier. It takes only 2 minutes for us to put a patient on the ventilator. It takes more than 2 weeks of conversations to prepare a patient and a family to not intubate the patient. So it is hard work, but it is not impossible. So over to you, Sridevi.
Thank you so much, Rajam, for giving a very brief overview about palliative care and respiratory medicine. So we can open the forum for questions. As Rajam said, it will be nice to know about your practices, or what have you learned, what is there more that we can add for the next time. So any comments are. Any questions to Rajan? Or any comments? We would like to hear some voices from you all, other than from the faculty and me and Raj Lakshmi. It will be nice to hear some.
So Suresh Kumar has asked one question is, what I understand is palliative care in the limited care setup. Are you trying to ask how to go about palliative care and limited care setup? I think half your problem, Dr. Suresh, would be if you acknowledge that there is an issue and then take help from other paramedical like physios, counselors. Like Sujeet mentioned, if you do not have a trained palliative care physician, you can take this help. Alternatively, you could also train yourself in palliative care. There are lots of small sessions, 10 days, 6 weeks, 1-year fellowship, which really does open your spectrum of how you look at disease and how you look at suffering, and therefore make a difference to the patient's life and your own clinical practice. Referral is the main question, madam. When is it too soon to talk? So thank you for asking this question. I thought it will become too elaborate in my talk, so I didn't include it. But typically there is a surprise question that has been researched in England about when to refer your patient. So in your mind, when you have a patient of an advanced lung disease sitting in front of you, you think in your mind, will I see this patient alive in the next 12 months? Or will this patient come to my OPD in the next 12 months? And if in your mind, with your experience, if the answer to that question is no, that is the time to integrate or involve your palliative care physician. The 2 documents I was talking to you about is the Blue Maple. You can Google search it, or Sridevi and team can send it to you, by Manipal, and also a gold standard framework where they have given you indicators in COPD. So for example, if the patient satisfies any of the two, which is elderly patient with severe comorbidity, severe other comorbidities, who has been to the hospital more than 3 times in the past year, or 1 time intubated in the intensive care, or if his pulmonary function tests have shown a deterioration, or he's on NIV and 24-hour oxygen. So if he qualifies or satisfies any two of the criteria, the probability of him going downhill and decline is much higher. Involve your palliative care physician is that. Sujeet, you want to add to that?
Yeah, Rajam. I think when you look at timing, Shivashankari's question, I think that's a very relevant question to a lot of our respiratory colleagues, actually. And so I think there's never a time written in stone here, and I think it can vary patient to patient. For instance, I think Shivashankari, you could have a patient with early IPF who is extremely worried about how the future is going to be and what he's going to do, who you could probably refer straight away and say that, look, I know you have these concerns, your disease is early days, but you want to draft an advance directive, you have questions. And so that's one extreme, I would say. And the other is, of course, when they're really so sick and dependent that you need much more than in-hospital clinic consults. You probably need home palliative care to look after them. So within these two extremes, anytime, to me, it's never too early, if I have to put it that way. I would say for any chronic illness, it's never too early, because if you have to talk of drafting an advance directive, I think you can do it when you're in the pink of health as well. So there is nothing as too early. But if you had to say when, I would say when your patient is sick enough that your pharmacotherapy is not going to do any magic, and your patient's expectations are more than you can deliver. And this happens very often in COPD and ILD, two classical examples. And as respiratory physicians, we have treated so much of asthma that we believe that asthma is, and patients sometimes see asthmatics doing so well that they believe, why shouldn't the other chronic illnesses also do well? And they don't. With simple pharmacotherapy, they don't. And so you need more, whether it's rehab, whether it's oxygen as pharmacotherapy, whether it's their mental health, or whether it's just conversations, all that is important. So never too early, I think, but don't make it late. I think that's important to remember.
Hi, sir. Good evening. I'm
Good
Dr.
evening.
Shivashankari.
Yes.
So I had a patient exactly of the IPF. So the same thing happened. So I referred the patient because I'm not much aware about the palliative, and neither my hospital offers a good, has a big setting of it. So the patient attenders became offended actually. So they were telling, we have hope in him. Why don't you guys have hope? And it was an IPF patient also. So this is not the first case I'm seeing, sir. This is like post-COVID and also COPD and all. So I've come across like 4 to 5 patients. So the first thing is the family gets offended, and the first question comes up is, why aren't you confident to treat it up? We'll take it. We'll have, you name it, we'll keep it at home. BiPAP, oxygen, nebulization, everything we'll keep it at home. But why you want to go for palliative thing? Or even a psychological or psychiatrical consultation, they are not things. So how well is it accepted, sir? What is the acceptance range? And do you come across like this? So what should we do when?
Sure. Very, very good question. Sridevi, am I still echoing?
No, it's your voice is not echoing, but when you are in unmute, the others voice are recording. That's all.
Oh my gosh, this is the worst part of integration, I think. Anyway, so Shivashankari, good question, and something we face every day. So you're not putting up an uncommon question at all. And I'm glad you raised it. When the family member, I think here you got to sit back, first of all, don't be aggressive, between suddenly withdrawing and saying, okay, do whatever you want to do, and being aggressive and saying, oh my goodness, this is not the best thing for your patient. We have to draw a middle line, Shiv Shankari, and be a little assertive here. And the only way to be assertive, Shiv Shankari, is if you know what is important in a patient's healthcare. Here you're talking about a relative. Okay, it's very important to understand that when you're dealing with your primary equation is with the patient, and the relatives come after the patient. So when a relative tells you, don't give up hope, you need to ask, the first question I would say is, what is the hope of your patient? And once you have that clear, I think your dialogue becomes a little more clear between you and the patient, and the relatives are there on hand. And then you, from the patient's hope and expectations, you move to the relatives' hope and expectations. And I think if it doesn't work on the first time, don't worry. There is never be aggressive on this. It is counterproductive, as you rightly said. Just be assertive and each time remind them. And sometimes I will see a patient whom I've told 4 times, and then they have a question for which I have no answer. And I say, look, you haven't met the palliative care consultant, because they will answer that question, or they'll be able to, deal with this issue better. It may take once, twice, 3 or 4 times, but assertiveness. Now, where does assertiveness come from, Shiv Shankari? It comes from a little bit of a mix of competence and confidence. So you need to know your disease well, which means you need to know COPD and ILD, and you need to reasonably know the patient's trajectory, right? We are not asking for accurate astrological predictions here. Reasonable knowledge of where this patient is heading, and say, look, this is where your patient is heading, or this is where you're heading. The next time you get into hospital, are you okay with this? We're fine. We will aggressively manage you. Do you think you want a little more comfort here, or if there are things you don't want? Then we may need to do it. And I had this problem, and I'm glad you brought it up, with a lady today who was twice on invasive ventilator, rheumatic heart disease, redo MVR, chronic kidney disease, and a moderate asthma. I'm involved only because of the asthma, which is the easiest disease to manage in her. But because of her redo MVR and chronic kidney disease, it's a nightmare, And she, on her last admission, said, I don't want to be on the ventilator, but the husband forced the primary nephrologist to ventilate her. Now she's come for follow-up, and I said, look, you went through that experience. And again, it was, why should I meet a palliative care consultant? I said, you told me you didn't want to be on a ventilator. Now you're off the ventilator, you're well. But you could again decompensate either on the kidney front or the cardiac front, and we'll be back to square one. So she's still thinking about it. And what you said is right, Shiv Shankari. The family doesn't want to lose hope, but she is sort of slowly warming up to the idea. If she doesn't warm up, no problem. And they have financial issues also. And I told her, your husband is going to get the money organized from somewhere or the other and ensure that you're ventilated again the next time. And if that's what you want, I'm fine with it. Then you pause and you wait for them to, but as I said, assertiveness is important, because when you know what's going to happen, and I think as physicians, we have the luxury of knowing a little more about the disease trajectory than the patient. So with that knowledge, just be a little assertive, but always step back when you find patients do not want to do it, but tell them, look, I think it'll help you. And if they're not happy with the word palliative, use another word, use supportive. What's wrong in that? Use quality of life. I mean, use anything else. Why do you want to use palliative? And if you use palliative, qualify it well, because 9 out of 10 patients I see in my practice do not understand or believe palliative care is synonymous with end-of-life care. And that is a very important distinction to make. And this is not just India-centric, this is world-centric. Please understand, barring the few countries on the top of the list, most people in the world believe palliative care is end-of-life care, and many physicians believe that. So you have to first deal with your colleague physicians, and that's why it makes such a difference when you have a palliative care consultant in the hospital, because the whole dialogue changes, right? And it's so gratifying to see that, both among suddenly the nurses see someone's listening to the patient and the family. So I know I've gone on for too long, but I hope I could.
So I just want to add a couple things. What I want to add here is that we need to try. And for that, we need to change our own mindsets. So I have had first few years, I've had disastrous results. I've had people walking out of my room and telling Sujeet, I never want to meet this woman again. So it's not that it is going to be, oh, come on, please talk to me about my life and death. It's never going to happen. So like Dr. Rajgopal always encourages me, saying first they will laugh at you, they will ignore you, they will fight with you. It will take at least 10 years or a decade to accept you. But we need to start somewhere, start those conversations. And that is the reason when the earlier you integrate and start these conversations, they have the time. They also realize how their body is not coping or dealing. They understand their bodies best. So if you're going to say just 2 centimeters outside the ICU, nobody's going to be prepared to listen to that conversation. Earlier you start, and then when you don't, obviously you suss the patient. If he's not ready for it, you talk about what is bothering you, what is your worry, how has life changed for you, it can be the weather, and leave it at that. Start building your rapport. I feel the fact that you're going to feel resistance should not be the reason to not try at all. You will feel failures. It's like doing a bronchoscopy. First bronchoscopy, you'll never hit jackpot. You keep trying to improve. Similarly, you need to keep trying the conversations. And palliative care is therefore also called narrative medicine. It's like doing a procedure. You slowly clear the knots in his head. But for that, you need the time. You can't say, okay, in 1 hour, now you solve all the patient's issues. It's not going to happen.
Shiv Shankar, are you clear on that, or any doubts or any queries?
Great. So basically, I should be slow and then go ahead and take baby steps at a time.
Small steps. Nobody's going to say, let's sit and chat about my death. That's never going to happen.
Yes, as you told, ma'am, I have patients walked out of my OPD, as you told. So that's why this subject is a bit tricky for me. That's the main reason I've taken this also, to first understand and have the knowledge so that I can use it for my patients who comes to the OPD.
It's tricky for all.
Sure. I'll just go through some of the questions on the chat box. Oliver has asked about his grandma having COPD and overlying ILD due to RA. Certainly a patient, it looks like, certainly a patient who looks like could benefit from supportive and palliative care, and Rajam will send you the papers, Oliver. Shah Jahan, the unrealistic expectations of the relatives, especially NRI relatives. I think expectations are always different from different relatives. So I think first understand what they are and what you can deliver on. What you cannot deliver on, you need to tell them. This is something that I really think is unrealistic. Be honest with them. And if they believe that there is someone who can deliver, tell them you'd be glad to hear how they will deliver on those expectations, and let them meet another person. It's always important to let them meet as many people when they have unrealistic expectations. And invariably they will meet even if you don't tell them to meet in such situations. Suresh Kumar has asked about palliative care sounding like an expensive affair. What is the average cost of palliation for one patient? So palliation is not, I mean, Rajam will answer this, but palliation is not a sort of, it's not like, Suresh, a one-stop shop. It's not like one patient can be palliated in so much cost. Palliative care is like in private medical care would cost as much as private medical care would cost. Palliative care and public care would be less expensive and almost free. So the average cost of palliation, one thing I can tell you for sure, is far, far less than the average cost of unnecessary and disease-specific treatments, which prolong life but not the quality of life. That much I can tell you. So the average cost of palliation is far less, but the patient sees the value in it as time goes on. Rajam, I don't know if you want to comment on
that. The way you to think about this is, if you see a patient of COPD with his multiple hospital admissions, ICU admissions, and if you involve a palliative care team, now necessarily we do take counselor and physiotherapy, etc. And you all must be sending your patients to pulmonary rehab. That's the physiotherapist we are also talking about. It's just that we also include counseling and nutrition for the patients. It is therefore looking at another specialist, but nothing compared to what a one ICU admission in a corporate hospital will cost. And you also need to realize the health economics in our country is that 55 million go below poverty line trying to keep their loved ones alive in the last 2 weeks of life. So if we can actually prevent those unnecessary futile medical interventions, there is a lot of money to be saved. And in palliative care, we actually try and tell the patient this is high touch, low tech. Investigations are minimum. Once you've decided the patient is not going to hospital, he just needs a family GP and a consultant on the phone. If he's not going to hospital, then there's no need to do blood gas, pulse oximeter, BP, check everything, send routine bloods. So we don't monitor patients. We do not investigate patients. There is no frequent X-ray. There is no scanning. We know this patient has to be kept comfortable and his symptoms are aggressively treated. So if you compare with your normal COPD to a palliative care intervened COPD, it's definitely very much cheaper. And the consultation charges in corporate hospitals is the same like how you would pay for a pulmonologist, or it is all decided. So it's not expensive at all. And it does not high. Yeah, Sujeet.
There was a question from Elamparithi Shankaralingam on many times our prediction about longevity goes wrong. So basically, I don't think I would predict longevity most of the time. I often tell the patient when they ask about lifespan that I'm not an astrologer, but having said that, they want rough estimates sometimes. So I think there is data on IPF. The mean survival is 3 to 5 years untreated. And for other non-IPF ILDs is definitely longer. For the connective tissue disease ILDs and myositis ILDs especially, the survival is far better, prognosis much better. You have a score called the DOGAP score, DOGAP, which you can Google and find. It's an excellent score to get approximate survivals. But remember, it does go wrong often because everyone is different. You could get someone with lower scores, but is actually physically fit or is mentally much stronger. And these scores sometimes miss out things. So they're just rough predictors. And I think by and large, we should focus on the quality. And you're absolutely right. Yesterday, a patient asked me, who probably I believe has another couple of years to live. And the only question he asked me is, look, do I really need to meet the supportive care consultant? Because I think I just want another 10 more years. So I didn't just know how to respond to that, because in your mind, you know that this patient has another year or two, and you want him to meet a supportive care, palliative care consultant. And then he pushes back this question saying, look, I just want 10 years. I don't want more than that. And so then you got to tell him, look, even if you survive 10 years, the quality of that life is going to be miserable. So I think we really need to look at the quality of your life for the next 2 years first, before going to the next 10 years. But these surprise questions don't just come from you, they come from the patient. And you need to be very clear on what you're going to tell the patient and how you're going to tell the patient. And it just comes with time. And yes, Oliver loved the goals setting. I think that's very important. And
one more thing on this unpredictability. I think unpredictability is the reason why the referrals to palliative care is less. Because patient bounces back, there is hope. Because we don't know the disease trajectory, unlike cancer, when you diagnose a patient lung cancer, the first thing in his mind is how long do I have to live? When you diagnose a patient to be COPD or ILD, that's not the question he asks, because non-cancer diagnosis is not perceived as life-limiting and life-threatening. It is therefore our duty to tell him that COPD is incurable at some stage. Interstitial lung is actually some forms of ILD is like some forms of cancer. But because of this unpredictable nature is why the referrals to palliative care is so low. And that is why very often one time he's gone to ICU, he's bounced back, he'll go again, he'll keep doing that. But is that what he wants? Is that in his best interest? And does that focus on his quality of life? So the unpredictable nature is our problem. Unlike cancer, where there's 5-year survival rate, 10-year survival rate, there is no such thing for non-cancer diseases. And that is the problem why it is waited till the end, till everything has been tried. So I think therefore that is a very important question. And because of that, families and this don't want to come to palliative care. So that is also important to realize. And one question here, Sujeet, is palliation for rural patients who come to emergency. So if you go to the website of Indian Association of Palliative Care, there's a whole map of India with palliative care centers across the country. And most of these rural areas, I mean, I can say that there is access to palliative care. However, most of these palliative care centers are catering to cancer, also because as historically, they were all started for treating cancer. They do not have the bandwidth to look at non-cancer, but they can treat the symptoms of patients with non-cancer, which is also important to keep the patient comfortable, because the ethos of treating the symptoms of breathlessness in lung cancer and breathlessness in COPD is the same. So therefore, you can get addresses of a nearby palliative care center by looking at the website of Indian Association of Palliative Care. Is there more questions?
I think Sevin Thampan has asked about whether it should start from the MBBS level. Of course, it should start from the MBBS level. And it's absolutely legal to offer palliative care without certification. I think you can do it if you don't. It's all about care. And as I put up in one slide, Sevin, it's about seeing the patient, and that's what David Currow, who is really a mentor of sorts in palliative care, taught us at a workshop, that it's just seeing the patient with another set of eyes. So there's no rocket science sometimes here, but it needs a skill set if you are going to specialize in palliative care. For sure, it needs a skill set for which you're trained and what you're doing in a way that many other specialists cannot. But just simply providing palliative care can be done by anyone. And sometimes you don't even need to be a medical professional, to be honest.
So one of the countries where at the point of diagnosis, integration helps is now what I see very often, maybe once a week, is motor neuron disease. So the neurologist whom I showed in my presentation, Roop, he sends the patient to palliative care the day he's broken the bad news to the patient that he has MND. Because honestly, this patient has got such an unpredictable life, definitely incurable, and will have a cognition throughout of how he is deteriorating. And it is a difficult disease to deal with for the patients and the relatives. You have young MNDs, they really don't know what's hit them. And you know that it is going to go downhill. And so at the time of diagnosis, it really helps for them to plan, finish unfinished business, get children married, travel, so many things in your bucket list. You really sit and discuss. It is heartbreaking, but at least at the end of the day, you feel you made a difference to the patient because he managed to do at least 5 out of the 10 things he wanted to do before he died. Very often colleagues ask, don't you feel morbid talking about this? I have changed the way I live my life. I live one day to the fullest. I really don't know what's going to come tomorrow. And it's really changed the way I look at life, the perspective of life, because it's finite, like how kids in Bhutan are taught to think of life. Life is finite. What really changes is the perspective of where you live. So whether you have a Mercedes or an Ambassador, as far as you have a four-wheeler, gets you point A to point B, that is what is more important. You need to have to do things what matters to you. Similarly for our patients. So we really need to get to be able to do what they want to do with as less difficulty as possible.
And again, on Shebin's question, do you need certification? Sometimes, Shebin, if you'll have an assistant in your clinic, whether it's sometimes a lot of young chest physicians I know have, a person who will teach the patient inhalers, right? Or will just give basic asthma education, because that's where they get their first patients from, easy to treat and very easy to rectify and get on the right track, normal quality of life. So those are the people sometimes the patient connects with, because they come to your consulting room or clinic or wherever, outpatient department, and sometimes it's familiar faces that they would like to talk to. So please do not forget considering putting them through a training course, and because if they listen more and they communicate more effectively and they can deal with symptoms and then just speak to you and say, okay, I think this patient needs morphine. All you got to do is prescribe it, right? But they are trained. So don't underestimate the competence of non-medical professionals or allied health professionals in providing palliative care. Please don't underestimate that and make use of it where you don't have full-fledged consultants around, and they can do a job sometimes as good as any other palliative care physician. I don't know what your thought on that is, Rajam.
I would say nurses, we ignore nurses. They are the best. So your to-be retired nurses, it's a nice 9 to 5 job for them to have. Send the nurses. They have a great connect with patients. They have compassion. They get to the level of patients. Sometimes doctors can be intimidating to patients. Patients don't ask silly questions about the toilet, the urine, so many things. It's easier about food. It's easier for them to talk to nurses. So even nurses are a great bunch to train, and they can do a lot of question answering for you and hand holding for you with the patient and caregivers. So I think don't forget nurses. They are the pillars of palliative care. In the West, they are the ones who do home visits. They are the ones who prescribe, write down prescriptions. They connect to the doctors, confirm what's to be given, and they have the right to prescribe even morphine and opioids. And that's the reason why they're able to deliver palliative care to people's homes. So nurses are the pillars of palliative care.
Thank you, Rajam and Sujeet. Dr. Shahjahan, one question to you. Can we take your case presentation on a session where we are discussing about symptom management? Is that okay to go ahead like that? Or because there are a lot of good discussions happening, so I didn't want to stop in between. So if you are okay with that, can we do the case presentation on another session where we are keeping exclusively for symptom management? Or if you want to discuss it today, we can do it also. So the ball is in Dr. Shahjahan's job.
Good evening. Is my slides visible?
I'm okay whenever.
Then we can go ahead.
Good evening. Good evening. Is my slides visible?
Yes, sir, visible.
Yes.
Okay. So let me start.
Yes, sir, please.
Okay. So good evening to you all. I'm really privileged to speak on this occasion. As a disclosure, I should say I have not get any familiar formal training in palliative care medicine or palliative care. So right now I am presenting a case of 68-year-old gentleman, the primary diagnosis of chronic obstructive pulmonary disease with the severe grade, that is grade 4. He's in respiratory failure now when he was admitted in the hospital. With the comorbid, he has comorbidities like diabetes mellitus, systemic hypertension, and coronary artery disease. So one second, I find it, yes. Now the patient presented with increasing breathlessness of 2 weeks duration, tiredness 2 weeks duration, and difficulty in walking and day-to-day activities for the last 7 days. So he has features of So he has features of severe core pulmonary, generalized edema, not able to walk or to perform his daily routine for the last 7 to 8 days. He was admitted in our center earlier 4 times during the last 1 year with breathlessness and features suggestive of respiratory infection. The whole event started some 21 years back. The just previous hospital admission in 2023 January showed severe pulmonary artery hypertension and hypercapnic and hypoxemic respiratory failure. He's an ex-smoker with a smoking index 1,200, stopped smoking 6 years back due to severe breathlessness. His overnight pulse oximetry in hospital showed profound hypoxemia with the SpO2 dropping to the 40s. A repeat echo when he was admitted here suggests severe pulmonary artery hypertension with the right ventricular systolic pressure of 78, but normal left ventricular and right ventricular systolic function. The patient is dyspneic with obvious features of increased work-out breathing. He is not able to lie down properly. His sinus is present. The sounds are grossly diminished. His extra in AP position, supine position was taken while admit and shows hyperinflation and probably bilateral lower zone infiltrates. And spirometry in 2023 February, when he was discharged last time, severe reduction in FEV1, that is 26% only, and DLC is also grossly reduced with the 4.82 milli per minute per mercury. That is normally is predicted is 29.5. So it is the DLC is grossly reduced, FEV1 is grossly reduced. So especially the graph, you can see that there is severe obstruction. And now he's on BiPAP with FiO2 to 4 liters per minute. Average SpO2 for the last night is around 84%, and 68% of the time patient had below 90% of SpO2. The minimum SpO2 recorded was 56%. Hemoglobin and other blood parameters are more or less normal, not that much problem. And what the patient was receiving before admission, patient was receiving tiotropium 18 microgram once daily through MD with spacer, salmeterol plus cortisone combination 250 microgram 2 puffs twice daily, salbutamol nebulization 2.5 milligram 6 hourly, metformin 500 milligram twice daily, injection human insulin 30-40, 25 units in the morning, 18 units in the evening, tab amlodipine, tab selmisartan for hypertension, vitamin D3 60,000 units per hourly every 2 weeks, tab clopidogrel, pantoprazole, tab acetylopram for depression. All these the patient is taking. So this coming to the psychosocial aspect, the patient is agitated, shows symptoms of depression and anxiety. He wanted to die, often pleading the caregivers and the healthcare providers to help him relieve the symptoms or help him to die. And now the patient is on BiPAP support, but still he is dyspneic. He is on nebulization with the salbutamol plus ipratropium every 2 hourly, formoterol plus budesonide combination 12 hourly, injection methyl xanthine 8 hourly, IV, injection hydrocortisone 100 milligram IVA 6 hourly, injection piperacillin tazobactam 4.5 gram IV 8 hourly, injection pantoprazole 40 milligram IV BD, injection plain insulin depending on the sugar values, injection heparin 5,000 units subcutaneous BAD. Patient is not on antihypertensives or antiplatelets now. So the main concern we had is that despite best of management, the dyspnea part is not improving and worsening day by day. Quality of life is severely affected and the patient is fatigued, depressed, and anxious. His spouse and children were also anxious as he is always symptomatic with no relief of breathlessness, even after all the medications prescribed are taking, including LTOT. So the summary is a 68-year-old gentleman diagnosed of grade 4 COPD with multiple comorbidities, presents with intractable breathlessness despite optimal medications. He is depressed, anxious with a reduced quality of life. His family members are also affected financially as well as psychologically. So coming to the discussion point, does the patient an ideal candidate for palliative care for respiratory symptom management? If so, how to initiate palliative care? And what are the pharmacological and non-pharmacological measures? Thank you.
I think Sujeet couldn't see some of the slides. So do you want to go first or?
No, it's okay. I got the gist of it.
I will go back.
No, it's okay. It's okay, Dr. Shajan. I have the presentation anyway. Rajalakshmi had sent it. I think to your first question, since with such a case, this is definitely a candidate for palliative care and respiratory symptom management. I think the answer to your first question is absolute yes. The second question, how do you initiate palliative care? Well, if you look at this patient, comorbidities, severe COPD, depression, financial issues, mental health issues, there's the initiation of palliative care here is, the first thing is tell the patient that you have no magic drug to treat all his problems. And whatever drugs you are prescribing to him are going to improve him to a certain extent, but you will need many more verticals of healthcare like rehab, psychosocial support, and conversations to help you just deal with your disease and its comorbidities better. And for that, I need someone from my supportive care team on board. And she will help you to deal with a lot of these issues. That's all. Just leave it. The question was, how do you initiate it? And that's how I would initiate. She's going to come. She's going to meet you. And then if necessary, after that meeting, we can meet together with her to figure out how best to achieve the goals of care, because the goals of care will be discussed by Rajam. And then I will come in and say, and then they'll ask me, look, is there no new drug, Shah Jahan? Or they'll ask me, can we not transplant the patient? All these questions come up when people have expectations and hope. A lot of these questions come up, and we deal with it one by one. And you have to tell them whether they're in the age group for transplant, whether transplant facilities are available in the city where you practice, and how practical it would be. Financially, they're already struggling, so that's obviously not an option. Also, transplant is not just an indication for transplant, but is the patient fit to undergo a transplant? So a lot of those questions suddenly come up when you have these discussions with the patient, which can be taken one at a time when the joint discussion happens with the palliative care consultant. What are the pharmacological and non-pharmacological measures? Well, I think you have used all the pharmacological measures possible, which many respiratory physicians, Shahjahan, do. They have our Indian pharmaceutical industries arguably amongst the strongest in the world. And we have all the drugs needed for COPD. We have all the devices, in fact, a range of devices available. And we have some of the best prices in the world. So you can't be in a better country, according to me, in the world if you're looking at pharmacology for the patient. Non-pharmacological is where respiratory physicians are getting better at, but a lot of that is done or is coordinated. So even if I mention go and meet physio rehab or use oxygen, the palliative care consultant qualifies how that oxygen is to be used, spends more time on what device, whether they're using ambulatory oxygen or not, whether they've done an overnight oximetry to use nocturnal oxygen or not, and whether the stress part is not their job and whether the stress part can be managed. Because some of the patients think, oh, palliative care must be just to manage my stress or my psychology. And then you have to tell them, no, it is to manage your overall health and your quality of life. And in that process, if we feel the patient needs a mental health professional involved, then we involve that professional. So it's integration of all this in the team. So it's hard to sometimes get a hospital that has all the right people under one roof. And so sometimes we outsource. So in one hospital where I work, They don't have a palliative care consultant. So we just outsource. We keep sending a request to the MD every week that we want to call someone from outside. And one day, as I think Shiv Shankari was asking, you keep doing it. One day it hits the MD's mind that, oh my goodness, why can't I have a palliative care consultant to improve the care of the hospital? Sometimes it never enters their mind, and sometimes it does. And slow steps with focused on both pharmacology and non-pharmacology. That's my summary of your questions. Rajam?
So the way I look at it is, main issue here is the gap between expectation, hope, and what you can deliver, right? Patients are upset because they have some expectations, you're not matching, and there's a big gap. So the way I would look at it is really sit down and ask the patient, what does he understand of his condition? So if you will see this in the communications talk also, is to first ask the patient what he knows of his illness. Once you sit and describe to him that in COPD, this is what happens, this is permanently damaged, this is not working, therefore I don't have anything to magically revert all this. I am giving you symptoms and I am giving you medications to bronchodilate, to make you feel less breathless, etc., etc., etc. And this is the much I can do. So this gap between expectations and what you can deliver has to be narrowed, because you need to explain to the patient the trajectory of the illness. After that, you ask him questions. So you say, I can't cure this for you. And unfortunately, this is how it will keep progressing. And all this is not done in one sitting if the patient has not got the bandwidth. After this is I ask the patient, do you want to know more about your illness? And then give him the information. And that's when we start telling him things that this can happen, or you can get more breathless, then you will need 24-hour oxygen, then you may need a machine called BiPAP. So we try to give them this information. And alongside with that, we talk to the psychologist to see if there's a family dynamic, there's something happening. If there's a financial issue, maybe the son doesn't want to leave his job and come and sit with the father in the OPD or the hospital. So we talk to the children separately. We try and understand the family dynamics. We see to it that the family has a GP. That's another dying art at least in the urban areas. Very few families have family physicians. They only run to specialists. But for such a patient in an emergency at 2 a.m., he's not going to get specialists all the time. So we see to it that they rope in the GP. We educate the GP about his condition and what should be done, and then slowly develop to talk to him about the goals of care, about what he would like to do, send him for rehab, make him realize the benefits of the rehab, that yes, with this, I could manage to do this, use of optimum oxygen to maintain between 88, 92, use low dose opioids, because you said he was breathless even on all that. Start the low dose opioids. And, once they see the difference of the exercise, the counseling, the oxygen, the opioids, and they slowly start trusting the fact that the palliative care person is interested in your welfare. Because one of the common questions we don't ask patients is, are you coping? Are you able to cope with your illness? It's not something we can ask, because we only don't know how to deal with the way he reacts. Because he can start crying, or he can walk out of the room, or he said, my life is hopeless. Then what does the chest physician do? He really doesn't know what to do. So this is the multifaceted way we talk to children. Sometimes, like today, the patient that Sujeet has referred to me, I went to the other hospitals. The son this is an advanced case of airway disease. The first thing the son told me on entering the room is, my father wants to be cured and he wants to go back home. And the way he spoke to me was, his face was not even looking, it's not even looking at me. He was opening some cupboard and removing some file. I want to take my father home and he needs to be cured. And so I sat him down and said, can you tell me what your father has? And he was blank. He said, my sister-in-law will come and she will tell you what she has. So this disconnect, he wants his father back, but there's no interest in the welfare of how much his father is suffering. The cough, incessant cough, not able to lie down. So there is lots of families, sometimes you realize that there is probably property matters, estate matters, the interest in the health of the person is not there. So there are small things. We might not be able to solve everything, but at least we should try and address and acknowledge, and therefore try to help the patient, because patient is our focus of care.
And very simply put also, Shahjahan, when you talk of breathlessness, and the patients are chronically breathless, these patients, and you brought that up on a slide. I think what I tell them is, look, I can treat your disease, and I expect your breathlessness to come down by treating the disease, but it isn't. And therefore, I need someone from my team or a colleague to help you deal with your breathlessness. And you've got to term it as a problem, because that's what the patient is perceiving it as a problem. The breathlessness is my problem. Forget the COPD, forget the ILD. I know you're a great doctor. You're just not able to solve my breathlessness. And I think that if you can integrate those two things, that, okay, we got your disease. I will be here if there's a new drug, a new clinical trial, if there's research coming up, I'm here. But when it comes to solving the patient's problem, we just don't seem to be there very often, And I think that's where the integration makes a huge difference to patient satisfaction.
Any more thoughts or comments? Because I think it is close to people's dinner time, or probably even past it. Over to you, Rajan. I think she's giving you feedback form.